Our next speaker is Dr. Dewedar from United Arab Emirates. The topic will be management of thalassemia in pregnancy.
Assalamu alaikum. Thank you, Prof. Amal, for inviting me for this conference, and thank you, Dr. Bordini, for introducing me. Today I'm going to discuss with you, away from the overview of thalassemia in the Gulf area or UAE, because Dr. Salam already covered most of the Gulf area overview and thalassemia and hemoglobinopathy. As we are advancing in age and improving of the quality of life of the patients and the survival of the patients is improving in our countries, with the advance of the chelations, a new era of management started to appear for us, and the new diseases also started to appear in the patients of thalassemia. One of the important issues is the pregnancy in thalassemia, because most of the patients now became fertile and they are able to conceive. So today I'm going to share with you an interesting experience of the management of thalassemia in pregnancy. As an introduction, as we know, thalassemia is associated with an increased risk for both the mother and the fetus during pregnancy. And while they have a high risk during pregnancy, with around 9 months of no chelations or little chelations, this group of patients, in addition to the other morbidities and other morbidities like diabetes mellitus, hypothyroidism, hypoparathyroidism, due to increased iron burden, this will put all of these patients, all of this group of patients under the risk of complications. In addition to the fertility and fertility issues and treatment of the fertility using human chorionic gonadotrophins and hormones, which will increase the risk of cardiac disease and volume overload, in addition to the thromboembolic manifestations and increasing the risk of developing diabetes mellitus. The most important risk for this group of patients are the cardiomyopathy in the mother due to iron overload, and with the consequences of the increased fetal growth retardation, which is a major risk for the baby. I'll start my talk by the case presentation for an interesting case, which is a 39-year-old beta thalassemia major Pakistani she has a beta gene mutation of homozygous for CD5. She had a splenectomy at the age of 2 because of the hypersplenism and pancytopenia. She was tested as PCR positive for hepatitis C at the age of 12, which is cleared spontaneously at the age of 15 without treatment. She had a spontaneous menarche at the age of 13. Then she developed hypogonadotrophic hypogonadism at the age of 17. She was diagnosed as a steroid-dependent autoimmune hemolytic anemia at the age of 15 years old, which failed intravenous immunoglobulin to control the disease. She was kept on azathioprine till the age of 35. She was diagnosed with type 1 diabetes mellitus at the age of 26. She had an MRI at the age of 29, showed severe iron overload with 8 milliseconds. She was kept on azathioprine, as I said, as a steroid-sparing medications till the age of 30, then stopped, got married at the age of 30. She developed decompensated heart failure immediately after marriage with ejection fraction of 25% and required long-term hospital admission, including ICU admissions for management of heart failure. We started for her an intensive chelation therapy using intravenous home-based chelation therapy, in addition to the desferal using a PICC line. And she inserted the PICC line for around 18 months, and the MRI T2-star heart improved gradually to 27, from 8 to 27 milliseconds with no hepatic iron overload in 4 years, with serum ferritin reduced from 5,000 to less than 300. Ejection fraction improved to 60%, it was 25%, and stopped anti-failure medications at the age of 35. She had an induction of ovulation by human chorionic gonadotrophin and got pregnant at the age of 38. The complication of pregnancy which she had, acute pneumonia with repeated ICU admissions during pregnancy, supraventricular tachycardia controlled by bisoprolol, aggravated immune hemolytic anemia, and it was one of the major challenges which we met during the management of these patients, and we and the blood bank suffered too much to find for her compatible blood, and we recalled all the donors during the last year or the last 2 years who gave her blood transfusion or donated for her blood transfusions to get her a suitable donor. We had a huge donor screening for that. She developed the circulatory overload after the 20 weeks of pregnancy with blood transfusion with symptoms of decompensations. Only during the blood transfusion she developed decompensations. She was in insulin Lispro and she was in insulin Lantus, but she shifted to Levemir insulin. She was in penicillin V 250 milligram BD, bisoprolol, Lasix daily, and low molecular weight and aspirin. She had an elective cesarean section and low molecular at the 36 weeks of pregnancy and low molecular weight at the 6 weeks after delivery. We continued low molecular weight heparin 6 weeks after the cesarean section. This sterile chelation continued from the 20 weeks of pregnancy till after delivery. And she got this baby after a long time of suffering from herself and from our side. So, to give an overview of the management of the patients with thalassemia and pregnancy, we have to divide the care for these patients into 4 stages: the preconception care, antenatal care, intrapartum care, and postpartum care. The preconception care, the main care for this group of patients in preconception is genetic counseling, particularly if the other partner is beta thalassemia carrier. So we have to offer to them PGD and IVF, PND by chronic villus sampling to get a trait patients, not a healthy patients, because they will never have a healthy child. So the preconceptional care, the conditions of concern which has to be controlled before the patients started the plan for the pregnancy is the diabetes, one of the major things. The fructosamine has to be kept less than 300 micromole per liter for at least 3 months prior to the pregnancy, and the hypothyroidism has to be controlled, and the patient has to stay euthyroid just before pregnancy, and the dose of L-thyroxine has to be controlled and has to be adjusted after pregnancy, because the bioavailability of L-thyroxine will be reduced once the patients will be pregnant, as it is bound to the pregnancy hormones. The cardiac status, it is important to evaluate how well the cardiac status of the woman will support the pregnancy, as well as the severity of any iron-related cardiomyopathy. The assessment should include clinical assessment, echocardiogram, ECG, cardiac MRI T2 star. A T2 star of less than 10 milliseconds has an increased risk of cardiac failure during pregnancy, and even without during pregnancy, it has an increased risk which the pregnancy will add to this risk. A reduced ejection fraction is a relative contraindication, but it is not an absolute contraindication, and the patient can get pregnant. One of the important things is that pulmonary hypertension is one of the absolute contraindications in patients to get pregnant with, and the patient has to have a written consent that she will get pregnant with pulmonary hypertension, especially in severe form of pulmonary hypertension. The aim of the cardiac MRI T2 star or the cardiac iron overload during pregnancy should be always more than 20 milliseconds, which is sometimes difficult to achieve. The medications which we have to take care before planning pregnancy, chelators, all the deferobrone and exudates are contraindicated during pregnancy and ideally should be stopped 3 months before pregnancy. Or once the patient will know that she is pregnant, she has to stop the Desferal and all the chelators. And the Desferal should be withheld during the first trimester and should be resumed after, if necessary, after the 20 weeks of gestation. Bisphosphonate, hydroxyurea, and high-dose vitamin D should be stopped before pregnancy, probably by 3 months before pregnancy, to avoid any teratogenic effect of this medication. Folic acid should be started very early, once daily instead of once weekly, to prevent any neural tube defect. Antibiotic prophylaxis, any patients on antibiotic prophylaxis due to splenectomy, they should continue the antibiotic prophylaxis with penicillin or erythromycin during pregnancy. So during the antenatal care, the frequency of the care, the gynecologist or the obstetrician should see the patients monthly until the 28 weeks, then every 2 weeks after that. A specific cardiac assessment should be done at 28 weeks of gestations, and thereafter at appropriate earlier or more frequent assessment for women known to have cardiac disease like our case. Fructosamine should be done monthly and should be kept ideally less than 300 micromole per liter. Thyroid function tests should be done monthly, and the adjustment of the dose should be done during pregnancy because the patients will have a clinical status of hypothyroidism even with adjusted dose before pregnancy. Early scan at the age of 7 or 9 weeks of gestations, in addition to the routine first trimester scan, should be done for these patients. Women should be offered the serial fetal biometry scan to diagnose early fetal growth retardations, which is very important in patients with non-blood transfusions, not on blood transfusions like thalassemia intermedia, and this is an indication to start blood transfusions for such a group of patients. For diabetic and induced pregnancy, earlier scan is recommended to diagnose pregnancy loss and multiple pregnancy. Still, we are in the antenatal care, the transfusion care. The target pre-transfusion HP should be always more than 9.5 gram deciliter, and this will enhance the patient's, enhance the fetus growth and prevent fetal retardations. In non-transfusion dependent thalassemia, regular transfusion should be considered if worsening of the maternal anemia and symptoms or evidence of fetal growth retardations. It's a very challenging in non-transfusion dependent thalassemia to start a blood transfusion during pregnancy because these patients are liable to develop autoimmune or alloimmune hemolytic anemia, which is sometimes it's very catastrophic and we cannot manage it during pregnancy. Hemoglobin should be monitored every 2 to 3 weeks to keep the target HP more than 9.5 gram deciliter. If regularly transfused patients, the trigger for the transfusion, if the HP is less than 80 gram deciliter, and this patient has high risk of alloimmunization, this is non-transfusion dependent thalassemia. What are the recommendations for thromboprophylaxis? All the patients who had a splenectomy or the platelet count more than 600,000 should receive aspirin as antiprophylaxis. But if the patient has both platelet count is high and the splenectomy, they should receive throughout the pregnancy low molecular weight in addition to the aspirin. And in general, any patients who are admitted, thalassemia patient admitted in a hospital for any care during the hospital stay, she has to receive low molecular weight heparin. What about the chelation therapy? Chelation therapy is a little bit complicated during pregnancy, but we have to know that the only chelator which is registered or approved to be used during pregnancy is this spheroxamine. And if it has to be used, it has to be used after the week 20 of pregnancy, not before that. And to be used, we have to have a justifiable cause why to use the Desferal during pregnancy. In general, the mild and moderate iron overload in the heart and liver is not an indication to start chelation therapy during pregnancy. Severe iron overload, which means that the MRI T2 star is less than 10, or if the patient has symptoms of decompensated heart failure, especially if the patient has a history of decompensated heart failure and he has a history of severe iron overload in the heart, is the only indication to start this spheroxamine after the 20 weeks of pregnancy. Signs of the cardiac decompensation are the primary indication for the chelation therapy, as we said. Women with T2 star less than 10 milliseconds are at high risk of cardiac decompensation. Desferal is only allowed if indicated. Dose should be not more than 20 milligram per kg per day on a minimum of 4 to 5 days, not before the 20 or 24 weeks of gestation. During delivery, thalassemia itself is not an indication for cesarean section, but we may recommend that this patient has to go for cesarean section, particularly if the patient has heart failure, and as it is not allowed for such patient to go to the third stage of delivery or third stage of delivery, because this can risk the heart. Chelation therapy has to be started once the patient is admitted for cesarean section, even before the cesarean section, and this will reduce the risk of arrhythmia during the anesthesia. Early cross-match for the patients with allo or autoimmunization, because the availability of the blood may risk the process. Continuous intrapartum electronic fetal monitoring should be instituted. Active management of the third stage of labor to minimize blood loss. A detailed management plan should be put in the patient's file before any planned cesarean section or any planned elective cesarean section. Pre-labor HP should always be more than 10 grams per deciliter, and this will improve the survival and reduce the morbidity in such a group of patients. What about the postpartum care? The patients should receive low molecular weight heparin 7 days after normal delivery, and this should be 6 weeks after cesarean sections. Breastfeeding is safe and should be encouraged even with chelation therapy, as this viral is not absorbed. It is expressed in the milk, but it is not absorbed through the GIT. And so the patients can continue desfloxamine, especially in high-risk patients. If the woman decided not to breastfeed, intravenous or subcutaneous desfloxamine infusion are continued until the discharge from the hospital or until resumption of the previous iron chelation regimen under hematology supervision. At the end, we should never lose hope in such a group of patients and invest in them to have children. Thank you so much.
Thank you so much, Dr. Hani, for this comprehensive talk and a good overview for the management of thalassemia in pregnancy. I have a comment. I think preconception, Dr. Hani, all the thalassemic females must go through IVF cycle, do PGT-M or pre-implantation genetic testing for monogenic, do sequencing for her and the husband for selection of embryos.
Yeah, if the father is normal, and already we have all the patients, we have the genetic mutations for all of our patients. But if the father is normal and the other partner is normal, it's not of benefit at all to do any genetic sequencing for the parents. For the patients, we have the genetic, but this will not cause any benefit for the baby himself, because all the babies, whatever the mutations, they will carry one of these mutations, and no benefit to know whether before pregnancy whether to know the baby will carry this gene or this gene. This mutation or this gene, anyway, he will come trait, whether this mutation or this mutations. But this is very important if the other partner is trait or carrier for any beta gene abnormalities before, any gene abnormalities for the beta gene.
Thank you. And now the floor is open for any questions.
Professor Kendi, I have a comment only for you. As regard the Dewedar
hemoglobin, yes.
Yeah, I know that this CD29 is almost 20% in the Indian population.
Right.
What's the difference between this? I think this coming from India,
right?
Originally coming
right.
from, because it's existing in India, but called codon only 29. They
right.
didn't name it Dewedar.
Right.
You name it Dewedar.
No, but it's a double
heterozygous. Yeah, it's a double heterozygous. Not a
not only one.
Okay.
Yes.
Thank you.
Professor Ilham.
Also for you. Thank you for sharing such rich information about hemoglobinopathy in Oman. As regards the sickle Oman genotype, what about the phenotype of this problem? Is it as severe as SS or a milder form, or?
Very important question. So the as I mentioned, the phenotype of these patients, many of them actually manifest. Well, I have one patient who had a stroke. They get acute chest. They get splenic sequestration. But I told you that the S-Oman level varies from between 8% to about 23%. The one who have less than 15, usually they don't have symptoms. They behave like a carrier, like a trait. But the one who have a higher S-Oman, 16, 17, 18, 21, 22, these usually have manifestations, number one. Number two, what we noticed is that the people who have alpha thalassemia with S-Oman, they have less, so if they have an alpha gene, they have less level of S-Oman and less manifestation. And what we are, and I said the third point about S-Oman is that we have not seen a homozygous S-Oman. Yes. So, because they probably die. But what we've seen also is that we have seen S-Oman with S, and they become transfusion dependent. And S-Oman with thalassemia, and they also behave more severe. I mentioned it's an African and a Mediterranean, so a classical African S mutation, codon 6, so plus and a Mediterranean mutation, the two together.
Thank you very much for this very interesting and informative session, and we have to close the session right now. Thank you for the speakers and the audience.